Welcome back to the peripheral series on my YouTube channel. Up next, after we did some of the leg anatomy, we're going to go into carotid anatomy. Now, I'm going to be really specific. I'm talking from a cath lab perspective. So this is more in the realm of just vascular work where we're looking for carotid stenting, carotid interventions. There's a whole other category, sometimes in the cath lab, sometimes in interventional radiology, the IR lab, sometimes in a hybrid lab, where we'll really categorize these as a neuro procedures, where you have stroke patients, you're doing embolizations, and that is up in the cerebrals. So we are going to take cerebral angiograms from the perspective that we're talking about today, but we are not doing cerebral interventions. So I'm not going to delve too deep into the anatomy kind of intracranial above the really, we'll say beyond the internal and the external. We'll do some of the branching that comes off of that, but nothing really distal besides looking at some of the cross-hemispheric flow. So let's dive right in. First of all is patient preparation. So remember, this is taking images really above the chest, which normally for your peripheral procedures in the legs, your cardiac procedures, you clear, the chest and the legs, but you don't really think about above the head. And there's a lot of equipment that we have on the patient. There's a lot of things the patient might have that you need to be considerate of. So number one, look at the positioning of these patients. So really to open up this space, because your carotid arteries are right here, sometimes there's a shoulder roll that you can put under to allow this kind of flexion of the neck, or some places now have almost like this gel donut that they put under the head to really put the skull lower and the chin can kind of come up a little bit. Now, not all patients physically are going to be able to move like that if they've had any like cervical work done. So make sure you communicate with the patient on what is comfortable for them, because remember, we could be in here for an hour or two, so you just want to keep that in mind. Secondly, look at everything that we're going to be imaging. Jewelry, specifically earrings, need to be removed, and then any necklaces also need to be removed. Notice here, I know this is really not what I wanted to show, but think about the nasal cannula. Normally, right, it kind of goes around the chin right here. You actually want to put it up on this position if you can. And you still want end tidal CO2 monitoring, but try to clear everything away from the neck if possible. That also goes for your leads. Make sure, they're not coming up here and wrapping around, or that they're really here and down for your EKG leads. Dentures is another one. Now, some people have fillings and those types of things, obviously not removable, but if there is anything removable in the mouth, please make sure that you ask the patient, like, do you have any dentures or removable dental wear, and that they can remove that prior to the procedure, because those arteries do kind of come up here and you are going to be able to see all of that, which you'll see in some of the images we go over today. And lastly, glasses. Okay, the patient doesn't really need to see, so please remove any glasses that they have, because again, those frames are going to be in the way. Now, carotid angiography. Angles wise, we can do AP, lateral, some like to do 45-degree obliques. Now, in the dedicated neuro suites, a lot of those places have biplanes for this reason, because it can take some of those images at the same time to kind of avoid that repeat imaging. So a biplane has not just our normal C-arm, but it also has bi for 2, a secondary plane here where it can take full lateral images. So if you're just in a cath lab suite, this is probably what you're used to, just this C-arm and not this extra piece right here. And what that means is if you're taking your lateral shots, you have to rotate this all the way around to match this orientation, which can take some time. And you should have lead shields here, and you will kind of have to swing those out and adjust those after you roll this over. And please be mindful of the sterility of the cover that you have on the flat detector as well. But this is what we are going to look at. We'll talk about the anatomy in a second, but I'll dive in here a little bit. So the aortic arch is here. You have your common carotid, and then you see it bifurcates. Okay, now notice, if we remember from before, the SFA versus the profunda, what is the kind of difference between this vessel and this vessel over here? Okay, one is more straight and one has branching. Well, the one that's straighter is the internal carotid. And you can think the reason for that is the internal carotid has to shoot all the way up to get to the brain, versus the external carotid We'll talk about the branching in a second, but it does have quite a bit of branching off of it because it stops here and it kind of goes to the face, to the jaw, to the thyroid, and different places. So it branches off earlier versus the internal carotid has to kind of go up to the brain, so it has that straighter shot initially. And take a notice here, there is a sheath right here that goes into the common carotid, and this is kind of going to be the positioning for a lot of our things. A lot of the times the lesion's going to be right here in at the bifurcation or in the internal, and you don't want to be mucking around in there with your equipment. The cerebrals. Now, this is what I was talking about, where we're going to take these images for the purpose that we want to look at perfusion to the brain. We want to see if we have any flow limiting lesions. We'll talk about cross-hemispheric flow in a second. Now, in the neurospace, you're going to kind of be chasing some ischemic strokes that have embolus all the way in these distal vessels. You could have brain bleeds up here, those types of things, and need coiling, etc. But there is obviously, for every branch, it has its own name. Different segments of the brain control different motor functions, if you remember that from your anatomy and physiology classes. But for the purpose of just diagnostic carotid angiograms or even carotid interventions, we are not going to go up here. We're going to look at it, but we're not going to muck around in there unless you are really working in that neurospace and in that ischemic stroke space. Okay, here's another example. If you start looking up different levels of strokes, what we intervene on, you'll hear about M1, M2 branches, and this is what it is talking about. Those are segments of the cerebral vasculature, I guess you could call it. What initially leads up to this is the internal carotid. So that is why we intervene on the internal carotid if there is a lesion, because if it's flow limiting up here, it affects all these different segments of the brain, and you can start to have those deficits. Now for us, really specifically, again, just in the diagnostic carotid angiography, we are going to stay in this common carotid space like you saw previously. Like I said, normally our lesion is going to be up here, and anytime you cross that with a wire, you are risking directly embolizing to these distal vessels that, remember I said, for our specific space, we're not really going to mess with and chase, and we don't want to cause an ischemic stroke just by diagnostic imaging, right? So we stay in the common carotid with our catheters. Can you take selective angiograms advancing into the external or the internal? That would mean moving this up here and taking just pictures of the internal and moving this up here and just taking pictures of the external. Can you? Yes, but really only experienced operators, or again, if it's a physician who is working in that neurovascular space, has those privileges, should really advance to those areas. Now, if there's lesions or thrombus in those areas, absolutely not. We don't want to cross it with a wire or stick a catheter in there, and again, risk embolization. And like I said, the lesion's usually in the bifurcation, and you don't want to cross it, especially if you're not anticoagulated. So let's talk about some labeling. Let me grab some of the colors here. So number one, this is the catheter from where we are taking the picture. I should probably label that. Remember, you have that bifurcation, so you have two options, right? Internal, external. This one has all of this branching here. So this is the external carotid. And then this one with the straighter shot up is the internal carotid. And then over here in yellow is some of that dental work that I was talking about, where you're going to get some of that artifact and some of that metal. And there's really nothing you can do about that. Okay, this giant thing here, this is supposed to be here, but it is just a marker. This is for right or left. This is the person's initials, the radiographer's initial. And then this is a ball of radiopaque beads to show the orientation of the patient. Now, this is the same image, but we're going to talk about some of those little branches. And if you've never really talked about or seen these before, I have a reference image on the right-hand side for you. So now notice all of these branches here are coming off of the external, right? So if we look over here, oops. This is the internal, and you see it's kind of coming up by the base of the skull. And then you have this external that is coming here down first, superior thyroid artery, which makes sense because your thyroid is down here. Remember where you wear your thyroid collar. And then up here, some of the other branches, you have the lingual artery. Then you have this one up here, that's the facial artery going to the face. And then all the way up here, you have the maxillary artery. So the ones down here that we're looking at, you have this first branch. That one is which one? Write it in pink. That is the, thyroid artery, right? And then what are some of the ones in the green box? Now there's a lot of overlap here, so it's kind of difficult to tell where the origin is. Good. Now you might have heard of the circle of Willis if you're studying for your CI or your RCIS. Sometimes it can show up on there, more on the CI than the RCIS, but I'm going to talk about it. This is the bottom of the brain. So looking from an inferior aspect, you have the vertebrals and then you have the carotids. Okay, notice at the base of your skull, kind of everything connects to your brain, right? As far as your nerves. Well, the same kind of thing goes for your arteries, which is why now there is a point at which everything connects, right? So for the arterial aspect of things, that is called the circle of Willis. So it's right here, they've kind of highlighted it in blue, and you have this connection network. That can be very, very helpful. It's a natural collateral pathway for your brain. You want to have it, you want it to function. So let's look at a scenario of where this would be helpful. So this is an image. This is, sorry, I won't skip. This is the common carotid. You have the bifurcation, so you should have the external and the internal. All of this branching, right? The superior thyroid, the facial artery, and the lingual artery. This one that's open is what vessel? If it has all that branching. The external, which means the one that's occluded is the internal. Not good, right? The internal is the one that goes to the brain. So how is the brain on the left side? This is the left common, left internal, left external. How is the left side of the brain getting perfusion? Like this, otherwise this patient would have severe deficits, right? That would be the circle of Willis. So if you see, these are the cerebral starting to be taken at overlay these two pictures. So you can see that the right side is crossing over through the circle of Willis to perfuse the left side. So you see this comes up and starts to perfuse the left hemisphere, right? So even though it's not getting this perfusion this way, it's coming up and over this way, and you're getting this cross-hemispheric perfusion. So really important. Obviously, we still want this to open. We want all of this to open so that you can get better perfusion, but this can definitely save someone's life. Now, injections. We talked about, if you notice, is this DSA or cine? DSA. Okay, so we're going to take it in digital subtraction angiography. Your patient can't breathe, can't move, all of that stuff. So you're going to say, don't breathe, just when you're injecting, and remind them to breathe when you're done. Because some patients will really follow instruction and hold their breath forever until you tell them not to. Now, what else is kind of in this area that could cause an issue with motion? Swallowing. Okay, don't breathe, don't move, don't swallow, right? And don't talk, of course, because motion of the mandible can cause some issues. Now, what is the squeaky toy doing here? Well, really this is mostly talking about when we do interventions, but any diagnostic can turn into an intervention, so it's still really important to do. You want a squeaky toy. Some people just do the contralateral side to where they're injecting and where they're intervening on, but if you're taking bilateral angiograms, you want a squeaky toy in each hand. And what you're checking for is not just them to be able to follow instruction, but also for the motor function of their hands. But hands and feet, you can check both, okay? You can ask them, obviously we're femoral access, sometimes radial, so you want to be careful. We're going to ask them to, flex and point their toes, squeak the squeaker in either hand. You can ask the patient questions or ask them to repeat a sentence so that you can check for their speech and their cognitive function. Now, we should always be mindful of air in the manifold or the assist, but this one is very, very important because we are directly below the brain and we are injecting directly into the carotids and the cerebrals, right? So you really want to make sure you are air free. You want to make sure if you're using the manifold or any syringe, it is free of any emboli or free of any thrombus when blood mixes with contrast in the syringe and sits for too long. So you want to make sure you're using clean flushes and all of that fun stuff. Now, what type of equipment are we going to be using? Well, first of all, J-wire like we normally do for sheath insertion, catheter insertion, but you are going to pull out a glide wire, especially if you're getting any of those selective internals or externals. You really want to use a glide wire above the arch, and mainly because there can be a lot of thromboemboli there, and you just want to be very mindful with navigation. Also, there can be a lot of tortuosity sometimes in the way that the branches come off of the arch, which you'll see when we talk about the different types of arches, and a glide wire can help you navigate that tortuosity a little better. We are going to use sometimes short sheaths when we're just, and this is a normal short sheath, 10 to 11 centimeters, when we're doing femoral access or radial access. But then when you start to get to interventions, you are going to use a long sheath, and I'll show you here. The sheath for those interventions will actually sit right in the common, so we don't actually do this through a guide catheter like we do through the coronaries. When we're intervening, we use a long sheath and insert stuff directly into the sheath, and it lands in here. So that is a little different. Here are some of the catheters that you can use for selective angiography of the carotids. You can use a Simmons sidewinder, and we call it like a shepherd's hook because that's kind of what it looks like. You can use a Berenstein. Both of these, if you notice, kind of have this hydrophilic coating. You can use a JR or you can use a Vitek. Vitek has more of that harsh curve as well. So the thing with the Simmons sidewinder, it is commonly used for certain type of arches, but this needs to be formed in the aortic root. So if you kind of go up and over, like you're going to cannulate the coronaries, and then you pull this up together as a unit so that it pops into one of the carotids. So it's a little different versus some of these you can just kind of wire and jump in directly. This one you do have to know how to form it and manipulate it in the arch. Some people also get a little worried about that, of getting close to the coronary arteries, doing anything in the root, I'm sorry, not the arch, and they might prefer one of these. If you're going radial, that subclavian can be very tortuous, and a catheter like this might not track really well, so they might prefer to use these also. So it depends both on access, the physician's comfort, what they were trained on, and also the type of arch and where the vessels come off. You might need one catheter to cannulate the left and a different catheter to cannulate the right. Know your arch. So before we do any type of entering into any of the carotids, we need to do an aortic arch angiogram. That is almost a requirement for all of these. It should be standard practice. So the hostility or the angulation of the arch, as well as where the carotids come off, can directly affect how simple or difficult it will be to engage them. Sometimes this also decides whether or not we can do an intervention. So the type of arch that you have, type 1, 2, 3, is where the great vessels come off of the arch. And as you see in the different types, this right innominate artery comes off lower and lower and lower. And then what that creates is kind of this harsher angle in getting up there. Now there are a ton of, not just the arch, but also notice this arch are almost all the same, but the location of the arteries and where they come off is different. So this one is the one you are used to. You have the innominate and the right carotid comes off of that, the left carotid and the left subclavian, and your vertebrals are up here. You might have heard of a bovine arch, where the left common carotid, instead of coming directly off of the aortic arch, actually comes off of the innominate. So you're going to cannulate both while in the innominate artery. Some people will want to go radial for that since they're both right here, but also that could be a very harsh acute bend. Now there's a difference between these two of where the left common carotid comes off of the innominate. Lower, closer to the arch, or is it higher where you have a couple of millimeters here? Or you have some people who have, this is really rare, a bicarotid trunk where everything comes off of this brachiocephalic trunk. The left common, the right carotid, the left carotid, the right carotid, and the right and left vertebrals. Now, the aortic arch arch angiogram is going to be 30 to 35 degrees LAO, very similar to the outlay that you use for your heart cath when you're cannulating the coronaries. And what it's going to do is open up this arch so that you can see the origin of each of these vessels. Now, everybody's different. Some people have different levels of tortuosity, so you might have to navigate that a little differently. Some people have really twisty-turvy subclavians that can prove to be difficult, but in general, it's going to be 30 to 35 degrees LAO. Now, this is what I talked about with the Simmons sidewinder, or sometimes Sim2. You are going to form it in the aortic root and pull it up. So you see here's a really great example. It's formulated here, and then it is pulled up, usually with the support of the wire to help maintain this shape, into the left or right common carotid. Considerations for carotid angiograms. Number one, sedation. A lot of physicians support minimal sedation, like 0.5 milligrams of Versed instead of 1, and sometimes 12.5 micrograms of fentanyl. It just depends. Some might even want no sedation on board until you know whether or not you are going to fix. Some, even when they're fixing, don't want any sedation at all. What this can help with is keeping the patient still, because any of that head movement can be really detrimental to our imaging and where some of our wires and catheters are. So you also want to ask the patient how they are with sedation. Some people get really restless and actually do not get sleepy at all or calm at all, and you don't want to exacerbate that. Some will choose to give Benadryl or something instead of conscious sedation like Versed and fentanyl. Just make sure you speak with the physician and don't assume this is just like every other procedure. Stroke and neuro assessment. So again, we are mucking around in the carotids. We want to know what the patient is like pre and post procedure to make sure we didn't have any deficits. That can also be a reason for not giving sedation, because when you give sedation, it can alter their mental status, and some people can kind of slur their speech, and it might not be because you did anything. It could be because of the sedation. So that's important to know. Atropine on hand. This is mostly for interventions because you do have the carotid sinus, carotid bulb there. And if we put pressure against it, you can get a vasovagal reaction. So that's actually expected when we're intervening on the carotid, when we're ballooning and stenting there. So we usually have atropine out and ready just in case we get that reaction. Some people give this prophylactically before ballooning, especially if the patient's already hypotensive or bradycardic. We'll give it kind of as a protection to raise their blood pressure and heart rate a little bit, knowing that we're going to balloon against that and probably get that response. And of course, make sure the patient can follow instructions to not breathe, not move, not swallow. Especially if we're intervening, you might have to do that under general anesthesia if they cannot follow instructions, because that really makes or breaks the procedure. All right, now of course, back on the neuro assessment, I just want to make this statement. So there's a lot of expert consensus statements that talk about the pre and post neuro assessments, but only during intervention. So we may not know we're intervening until we're done with the diagnostic, and you can embolize plaque or thrombus just from wire and catheter manipulation, especially if there's something in the aortic arch. So follow your hospital protocols, but the neuro assessment can really help you identify any complications early on. So if you perform this assessment after, like in between, after the diagnostic but before the intervention, remember the patient's already sedated. That isn't their everyday normal. You really want to make note of that, because then when they come out of sedation and do the neuro assessment again, I mean, they should improve, right? But that's what you're comparing to. So you just want to be very meticulous in how you're documenting that. So if there's change of hand or change of shift, or someone relieves you during a case, that they understand that, you know, I did this assessment after the patient was sedated because I didn't do it before, et cetera, et cetera. Thank you so much. This one was a little short and sweet. And up next, we're going to talk a little bit about the renals and renal interventions, and then we'll start to go into different devices. Thank you so much. Make sure you like and subscribe if you want more videos like this, and I'll make sure to add other videos here and there to the different playlists that we have. I just know a lot of students are going into their peripheral semester before graduation coming up, and a lot of people are studying for the CI, and a lot of this is on there.